The key purpose of the user guide is to support all health service organisations to implement the National Safety and Quality Health Service Standards, specifically around meeting the needs of people from migrant and refugee backgrounds. Australia's population is highly diverse. About half our population is either born overseas or has a parent born overseas. And Australia has a robust migration and humanitarian migration programs. People from migrant and refugee backgrounds make significant contributions to our society and our community. However, for migrants and refugees, there can be many barriers to accessing and experiencing quality and safe healthcare. These barriers go way beyond issues of language, and they include health and healthcare system literacy, structural barriers to accessing healthcare, and how we support our healthcare workforce and healthcare systems to work effectively with this significant and growing population cohort. While, of course, all relevant actions in the safety and quality standards should be implemented by health service organisations, there are some specific strategies that health services can apply to meet the healthcare needs of migrants and refugees when implementing the NSQHS standards. 3 of the 8 safety and quality standards are particularly relevant and addressed in the user guide. These are clinical governance, partnering with consumers, and the comprehensive care standards. The user guide that's being launched today is a unique resource supporting health services to implement the safety and quality standards and provide safe and high quality care that meets the needs of people from migrant and refugee backgrounds. Importantly, the user guide is the achievement of many individuals and stakeholders. We are truly grateful to everyone who's provided guidance and advice and those who participated in the consultation process. Today, we've got the opportunity to hear from the experts and the stakeholders who've been involved in this work. We're going to hear from a distinguished panel of experts, followed by a Q&A session with the audience. But before I introduce the panel, I'm just going to hand the microphone over to Carla Wiltshire, who's the CEO of the Migration Council of Australia. And Carla's just going to say a few words now.
Hi, everyone, and thank you so much, Kim. I want to acknowledge your leadership in terms of the Migrant and Refugee Health Partnership. For us, it's been a fantastic partnership, and this in particular represents a wonderful and high impact piece of work, one that offers really practical strategies in healthcare settings. And so I want to acknowledge the partnership both with the Commission and the Migrant and Refugee Health Partnership, and thank our panellists, and also acknowledge the work of the team, and in particular Gulnara, for leading the strategy on this.
Okay, thank you. Now today we're delighted to be joined by Conjunct Professor Anne Duggan, who's the Chief Medical Officer of the Australian Commission on Safety and Quality in Healthcare. Professor Irwin Lowe, who's the Chief Medical Officer and Group General Manager Clinical Governance for St Vincent's Healthcare Australia. Dr. Margaret Kay, a GP with over 30 years experience working with refugees and the clinical lead in multicultural health with the Brisbane South PHN. And Tana Rishnu, who's the Deputy Secretary of the Primary and Community Care Group within the Department of Health. We're also very pleased to welcome Dr. Nadia Chavez, a general and infectious diseases specialist who is passionate about partnering with people and communities, and most recently has been doing some pretty amazing work with multicultural communities in Victoria throughout the pandemic. So Nadia, over to you to chair our panel and lead our discussions.
Thank you so much for having me, Kim, and welcome to everyone. I just wanted to say I'm sitting on Boonwurrung land, and wherever we are in Australia, we're sitting on Aboriginal and Torres Strait Islander land. This land was never ceded, and unless you're Aboriginal and Torres Strait Islander, and I want to pay respects to anyone here in the audience who is today, we're all migrants and we're all settlers in this country. It's worth recognising that. I'm really excited to be chairing this panel because these issues and these standards are issues very, very close to all of our hearts. We've been working in healthcare for such a long time. And I'm with this amazing panel of people. I'm sure we've all wanted to do exactly what is outlined in the standards and have been trying to do this for a very long time. And to have it actually a part of our national clinical standards, I'm hoping will really shift the way that we do things across different aspects of healthcare in Australia. Because what's embedded in clinical governance, partnering with consumers and comprehensive care should actually cater to the needs of every single person who accesses our health services, but we know that's often not the case. I've got a few questions to ask our panelists today, and then what we'll do is we'll open it up to the audience for your questions as well. And I'm looking, there's 130 people on here today, which I think is quite impressive considering many of us are in lockdown, we've got homeschooling, we're battling COVID in our healthcare systems. I want to thank everyone for coming today, and I hope you're all looking after your own well-being as well, because it's not an easy time for many people. So to start with, I wanted to start with the positives that you can see in this guide and ask our panelists maybe in turn, is there any particular action within the guide that resonates with you? I'll ask for a hands up who wants to answer that question and tell me, you know, what is it that resonates with you in particular, and how could you actually, how have you done things that are in the guide before? Teach us all, because we'd like to know if you've done something in the guide and made it work. I'd love to hear your story. You can pop your hand up or wave to me. Who wants to talk first?
Oh, Mike, if I may.
Oh, okay.
So Nadia, I remember when the standards came out and I was the Director of Clinical Governance, it was wonderful to have the spotlight shined on safety and quality. And I see now this user guide and allows an organisation to really shine the light and ask the question, how are we doing? Gosh, have we really thought about this now? If we just read the guide and think about what it's saying, how well are we doing? Can we do better? And I think it's a wonderful thing to have something like this, which, and I'm obviously very biased because I work for the Commission, but it was very much a partnership. But I think it's wonderful to have something that's very practical and allows, it says, this is important, let's stop what we're doing, let's think. Now let's just think, can we do better? And there's always, can we do better? And often when we think, can we do better, we've got no idea what to do next. But I think it's wonderful to have something that says, well, here's a very simple thing you can think of doing. And it means that there's something for everybody to do. And that's terribly important with complex organisation. I think that everybody can do something, and it's exactly right here. So from the leadership of the organisation, it's a great opportunity for the board and the executive to lead, but it also allows everybody, no matter what you do, you have a role to play. And the guide, I think, can help people to think about, well, what can I do differently to just improve healthcare that little bit more for migrants and refugees? So that would be my take on it.
Thank you. Margaret, did you have something to add? I think you had your hand up next. You have to unmute.
Yes, we can improve that. Okay, sorry, Nadia. Yes, I didn't want to see you feeling stranded there when no one was putting their hand up. So basically, I'm coming from the primary care perspective, and I agree with everything that was just said. And most people see the user guide or see the actual standards as being very focused on hospitals. And I think we need to understand that this actually works in primary care as well. And so if I just take an example of comprehensive care and developing the comprehensive care plan, it's simply not possible unless you're engaging with the patient from the patient's perspective. And unless you're actually able to engage with the patient, you can't understand the patient's perspective. And that includes delivering culturally responsive care. It includes ensuring that you have adequate communication with interpreters if that's required. And there is such a large proportion of our community, as you pointed out before, but a quarter of Australians were born overseas, or more than a quarter. And in the 2016 census, 80% of those had arrived only in the last 4 years prior to that. So that's a huge number of people who are very likely to need communication support, so use of interpreters, and also an understanding of the cultural background that they're coming from to be able to deliver really safe quality care. So that's a very relevant issue for us when we're delivering care, and equally relevant in primary as well as other care.
Absolutely. I couldn't agree with you more. And I think I loved it when the standards came out, actually, because suddenly I saw people really paying attention to safety and quality in a way that they never had before. And it was like, wow, this actually works, having been in, I work in hospitals as well. And if we can see this making a difference for refugee and migrant healthcare, it's very, very exciting. Go Tanya.
Thanks, Nadia, and thanks for the invitation. Can I acknowledge the leadership? And this is such a great practical example of the partnership, the Migrant and Refugee Health Partnership in action. So can I acknowledge that? Can I also acknowledge that I sit on Ngunnawal land in the ACT, and for those in the ACT, and I know Victorians and New South Welsh people have been in lockdown for a lot longer than we have, but what a time of importance of having those clinical safety and quality standards when, and once again, picking up on what Margaret was saying around comprehensive care. In a week where so many of us are in lockdown, in a week where, and a time when so many migrant and refugee people are feeling extra isolated and increasingly, distant from safety and quality and, a partnership approach, this guide is a really important tool. Can I thank the Commission? And for me, it's so encouraging to see the Commission that is, nationally and internationally respected and regarded do this work, because that actually gives it such validity and such huge reach across the health system. So lots of thank yous. I'm really, really excited to see that comprehensive nature of the guide, but all of those tools and suggestions and reflective questions that actually allow health services to partner and understand what genuine partnership is with their community. So I'm really excited and I'm thrilled to be part of the panel. Thank you.
Thank you. I'm actually, we're saying it's really great. It resonates with us. This is awesome. But can you tell me, and I'm going to go with you, Erwin, because you haven't said anything yet.
Sure.
What are some practical strategies for supporting it? How can we actually make it happen? Because it's great. I think it's such a great first step to actually name it and say, we haven't really addressed this and named it as a really important thing. But where's that next step? Maybe you've already done it in your hospital, in your healthcare experiences. I'd love to hear.
Yeah, it's a very good question. And I think in the chat at the moment, people have been asking that question. How does this apply to the hospitals? And I think the first thing to say is that, and you pointed this out, putting it on the map is important, making it obvious, making people realize that actually migrants and refugees are a proportion of the population that are potentially vulnerable and are disproportionately affected by health issues. So I think we just need to, by highlighting that, it puts the focus on hospital CEOs and quality managers in hospitals. And I think Margaret makes the point, not just in hospitals, but in health in general, that this is a vulnerable population. They do have socioeconomic determinants of health that mean that they're at risk of both physical illness, whether it be chronic disease, whether it be infectious diseases from the different countries they're from, or genetic diseases, and then mental health. I mean, I think for people who work in this area, we understand that there's issues of isolation, loneliness, family, fractures and things. And, there are examples of cases, for example, where, in some countries, postpartum depression is very rare. But when people from those countries come to Australia, where they're separated from their families, they develop a higher incidence of this kind of mental illnesses. So understanding that is an issue for them. And then making sure that health systems cater to the health literacy issues to do with this group of people because of language, because of culture. And I think the key here is highlighting them so that as we design systems of care, which are meant to be patient-centered, we overtly look for any structural systems that might discriminate. I think, and we have Tanner referred to the pandemic at the moment. The pandemic has, if anything, it has highlighted structural systemic discriminations within health systems in different countries that have been exposed. Basically, they've always been there, but in during this time, we're seeing more impact of the pandemic on people from in the UK, for example, people from BAME backgrounds, Black, Asian, and minority ethnic backgrounds, or in America, the African American patients are disproportionately impacted by the effects of the virus. And so I think, by highlighting this, it means that we can't avoid it. It means that it's on the books, it's documented. But ultimately, for me anyway, I don't think it's a matter of having it as a compliance thing. I don't think it should be a checkbox thing. It shouldn't be on a checklist to say, oh yeah, we've dealt with people who are migrants and refugees, we dealt with this and that. But I think it's more about ensuring that behind the lists of criteria that people have to comply with, we try to build empathy. We need for health systems and people who run them to see refugees and migrants as human beings as well. Like, they need to understand that they are people who have family members. They could be your brother, they could be a sister, even though they look different, even though they speak a different language. And I think for me as a migrant, it's easy for me because I know exactly how they feel. I've worn their shoes, but I mean, for everyone else in the health system, it's about developing empathy. I think without that, this is just then becomes just a checkbox exercise.
Thank you so much for raising that, and so early on, because I actually, it's a big kind of unsaid thing in the Australian hospital and healthcare system that there is racism. And I got an email actually from someone in a hospital system I won't mention the other day, who said, oh, look, we're thinking about putting some standards in for trying to make sure that people get access to interpreters. And look, I didn't want to call it racism because that might be a bit of a strong term, but if they don't get interpreters, that means they can't get the right healthcare. And I said, actually, it is. That's the definition of structural racism. And so I'm sure everyone on the panel realizes, but to actually say it out loud, you guys are breaking down structural racism just by having this standard in a way that isn't done very often in our Australian healthcare system. So naming it is important. But then back to the practicalities. Have you done it? Who's done it? Who's had a go at actually implementing something that's already in here in a way that has made a difference?
So Nadia, I'd just like to say that in the primary healthcare sector, sometimes we have the little bit of an advantage here. So firstly, this is an amazing asset for us to have what's basically a systems approach, a systems understanding of what needs to be there. But then we have in our general practice environment, the opportunity to do what we need to do. So we can actually very quickly step into this space. We have that flexibility, that agility. And it's one of the advantages of our primary healthcare system is that it can be agile and be responsive to what needs to happen. So just a very small example is exactly the sort of thing that you're just describing, is actually even questioning, well, you know, how can we get to ensure that we have interpreters? Well, that's an important question, even in a primary healthcare setting. And the answer is, first of all, everyone, even those who are in the administrative area of the practice, need to know how to get an interpreter, because my patients can't access me unless they actually make an appointment. So if my administrative staff can't actually ensure that the person who comes to the desk or the person who rings doesn't have access, if they don't have access to an interpreter, they can't actually make that appointment. So everyone in the whole place needs to be able to do that. And to have a system in place that everyone, at the moment that they start working in our practice, is one of the priorities is to learn how to use interpreters and to know exactly where the information is, how to do that and how to do that now. Now, it sounds like such a small thing, but as you say, it's something that has a huge repercussion on the entire of the delivery of care in the entire practice. And if you can do that without thinking this is super complicated and oh my goodness, you need an interpreter. If you actually do that because this is our normal practice and you smile, then people love it because they know that they can actually get the support. No one minds waiting if they know that someone is caring and the smile says a care. So I think just actually ensuring that the staff across the whole board are all understanding the purpose. And then I think there is a really important factor that the clinicians who are caring for patients in this situation should actually then feed back a positive feedback to the administrative staff who may not see how important that is. So we actually need to do that feedback within our own practice, and it makes a difference.
Absolutely. It absolutely does. But what you're talking about is culture change, aren't you? From the minute that person walks in the door, right up until they have their follow-up with you. And to actually change that in organizations can be tricky.
I think, Nadia, one of the things that stand out in my mind is going to Moree Hospital, small country town. We walk into the ED and welcome is said to you in every language you can think of. That was years and years ago. So I think we sometimes think, oh my goodness, it's all too hard. I'm only a little place or I'm only a person. But in fact, there is just, if we just chip away, there's so much we can do. And I often think when I read this, I think about going into another country where I don't speak the language. We know what helps us. And if we put ourselves into the feet of people who don't have English for a first language, I think there are many, many little things that we can do tomorrow. We don't need an enormous amount of resource. We don't need the CEO to sign off on it. There is just so much to be done that will make such a difference.
I couldn't agree with you more. I think many of us, and I've known Margaret for quite a few years, I've followed Erwin online, but many of us have tried to do this in our own little sphere. And Kim, I know, for years, and Gulnara, to have this here, and it's funny also with the pandemic, it's that disproportionately has affected people from migrant refugee backgrounds, including in Sydney Southwest, in Melbourne's Northwest at the moment, in the Southeast. I'm actually meeting more allies in this space. I don't know if you guys have felt that. Suddenly it's okay to talk about racism out loud. It's okay to say we care and we can see this is having an impact. Because I think sometimes we've tried to address this before, and I'd be interested to know if you've experienced this, but people have said, well, where's the proof that it's made a difference? So that kind of leads to my next question is actually, how do you know this has made a difference? And I've had that question with person-centered care as well. And I love that the standards had that, because then I could refer to the standards and say, well, actually, it's not just me thinking it, but how do we know this is going to make a difference? And how can you actually prove it?
I think one of the things about,
No, go for it.
no, I was just going to say, I think we should measure. Sometimes this has shone the light on a really big problem. We talk about equity and we think about equity, but often we think about it in terms of geographical distance or other things. This has really shone a light on inequity based on your first language, your literacy. And I think we need to measure. It is not hard to measure. Measure the number of times people who come to at the service we have and who don't speak English, how many times did they get an interpreter? How many times did we actually, and it's just counting the little stuff, and it makes us reflect, because all we have to ask ourselves is, could we do better? And I think that's what we really, how this will make a difference is everybody at every level, whether it's hospital system or it's primary care or where it is, if people just think about it and start measuring it. And it often becomes a surprise that when we don't think we're racist or we don't think we're inequitable, we really are, and we can do better. I'll stop there.
Tanya, did you want to add something?
I was going to add, and I love the fact that Anne went to measurement, because I mean, so often the old adage, you know, what matters is what's measured. And if I look at the examples of really great research and what we know about providing culturally sensitive care, for example, in Aboriginal medical services and Aboriginal community controlled organisations, there is a huge raft of evidence that says when people feel welcome and safe, when people can walk through the door and see themselves reflected in the staff, when people actually get holistic care and, you know, consumer-centred, their healthcare outcomes are much better. We've got a raft of evidence. This standard is built on that evidence. The thing that I love about this is there's a whole range of tools for people to go to, because one of the things that we come across often in the system is people are even afraid to venture into that conversation. People are afraid of labels. People are afraid of misstepping and doing the wrong thing. But when they've got a tool and a guide and a partnership that can help guide them there, it's a much safer place for health services to go. And, you know, in effect, that will impact on patient measures. In Aboriginal community controlled organisations, the kind of services that we provide, we have a set of 10 national key performance indicators, and they are measured in terms of outcomes. We have a similar set of quality indicators in primary care, and Margaret will know about them. How do we make sure that those quality indicators take into account this standard, and how do we get patient-reported experience measures? How do we get patient-reported outcome measures? Because that will make a big difference.
Erwin, was that you that was going to add something to that?
Oh, no, I'm happy to say something about that. So from my point of view, the ultimate measure is health outcomes for the migrant and refugee population. I mean, that's the end point. So I think the proof is in the pudding. Whatever we put into place, if it improves the health of those populations, those people in the community, then we've done our job, right? And then you work backwards. So health outcomes is one thing. And I think you ask them, are we doing a good job? And then you look at process indicators, process measures, you know, are we doing, how many interpreters are we using, all of those things. And then right at the front end, you know, which is what the accreditation system is meant to do, it will measure your compliance against the criteria, the recommendations that you're expected to do. But in the end, though, you know, it is about those communities. And I'll make the point as well that when we talk about migrant and refugee patients, that is a massive, very heterogeneous group of people, very, very different. And there is no one size fits all here. You know, it is a complex area, and I think at a high level, you know, we can have this criteria, but ultimately, I think the biggest thing that we need to do is to understand that the current, we just have to, as people have said, we need to acknowledge that the current system does have structural, I mean, I didn't use the word racism, but you can say that there is structural discrimination built into the system. And we need to continually test it so that we find where we can continue to improve, because, you know, it's all unintentional. This is unconscious bias built into the system, right? And good examples coming out of, for example, how when there's a lack of resources, how do we allocate and prioritize patients to those resources? And you'll find that if you just use prognostic factors, or a lot of the clinical trials are based on a particular population of patients. And so then if you apply then a heterogeneous group of people through those criteria, you get systematic discrimination against another group of people. Just because they've got a higher level of disadvantage, they will never again get access to particular care. And so those things are being highlighted through the pandemic, but they've always existed. And so to give an example, at St. Vincent's, we are looking at prioritizing healthcare through the lens of justice, to the extent that, you know, during times of peace, let's just say, you know, without a pandemic, we would, for example, be providing, preferring care towards disadvantaged groups, like someone from an Aboriginal or Torres Strait Islander background or a homeless person. During the pandemic, it should be exactly the same. You know, people might argue, oh, hang on, that's just discriminating against other groups of people, but we've always done that because they are disadvantaged. So that's something that is not easy to do, but you know, something that we have to think about from the migrant and refugee health perspective as well.
Thank you. And I think what all of you are talking about actually is intersectionality. So, you know what, if my mother-in-law, who doesn't speak English, has an educated English-speaking, university-educated doctor as a daughter-in-law, her healthcare outcomes are going to be much, much better than if she didn't speak English, had no family, was from a socioeconomic background that was disadvantaged, had a disability, had no social supports, et cetera, et cetera, et cetera. And I think it's actually quite challenging to have data maybe that demonstrates these things. And as a little disclaimer, I know, because I tried to look at this a few years ago. And, you know, even, you know, this is not being looked at even, let alone on an individual health service level, it's not being looked at a national level. And I find reports in National Health, Australian Institute of Health and Wellbeing has got a line in it that says da 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 da, and there are poor outcomes for people from certain diverse groups, or like that kind of, it stops there. We don't actually know, well, what does that mean and how can we unpack it? And I feel like these standards are going to help us unpack things a little bit. Margaret, are you about to say something? It looked like yes.
Well, if that's okay, Nadia, I think one of the things that we're talking about here is the fact that we actually need to identify some baseline demographics to actually then put the health outcomes beside. Because it's all very well to be recording the health outcomes of, you know, John Smith, whoever that might be. But if we don't know what their country of birth is, if we don't know what their cultural background is, which is often different to their country of birth, particularly in the refugee communities, their year of arrival. So have they only arrived recently and don't understand our healthcare system, or have they been here for 25 years and have worked out that they've got their own GP, a really strong relationship with that GP and actively involved in the healthcare system? And, you know, what is their language preference? What language do they speak at home? And just as importantly, do they need an interpreter? Because many people speak a language other than English at home. Even about 8% of people born in Australia speak a language other than English at home. You know, so this is really important, but not everyone needs an interpreter. And the need for an interpreter is very likely to be a significant demographic item that we need to include when we're actually looking at the health outcome of people with, say, diabetes or whatever it might be. So we can easily download the HbA1c, but we can't easily work out what a person's cultural background is to match against that HbA1c as the data stands at the moment. And if we actually have that collected in both primary healthcare settings as well as tertiary healthcare settings, we will actually have a huge volume of information that enables us to support those who are most vulnerable.
Absolutely. And we're seeing this all the time in Melbourne as well. You know, we haven't yet, you know, for vaccinations, I'm working in the vaccination space, trying to improve vaccination for people from diverse backgrounds. And unless we have the language, the country of birth, the ethnicity, the cultural background. We know in the Northwest, you know, a huge percentage of people Australian born, English speaking on the census, but come from very diverse cultural groups that need to be tailored in their access to various services, as everyone does. Comes down to person-centered care, doesn't it? And partnering with the consumer, which, sorry, this makes me very happy, this discussion, because I know we've just got to work out how to do it. So that comes to my next question is, you know, what do you see are the major barriers, and have you got tips for how to address these? You know, we've talked about some of them, but I'd love a barrier and then like a tip. Just line it up for me so we can take home some learnings and get going with this.
Well, I might kick off, if I may, and I can only speak from having worked in a health service rather than having ever worked in primary care. I think one of the barriers to now is, up till now, is that we haven't shone the light on it to the level we are now doing it. So it's like, as I was going back to when I said, when the safety and quality standards came out, suddenly in the health district, there was a big light being shone on safety and quality. Having a big light now being shone on this issue of the healthcare we're providing to migrants and refugees means that that's one barrier that's been lifted. It is now an expectation that the health service at the top level will think about this, look at this, and drive change. If it's not a subject of conversation at the top, it may be a subject of conversation in pockets at the bottom, you know, at the front line, but it's not systematically. I think this is we'll see change because it'll come from the top, shining a light and asking it. You can see that sort of there'll be expectations. People will start to, as Erwin said, look at the data. Why are there variations in outcome? Let's think no longer just about geographical difference. Let's think about ethnic difference. Is there something about it? Let's think. We often think about socioeconomic disadvantage. Well, let's add an extra dimension to this. I think that just having, I think that the user guide will lift a barrier of almost like a blindness to this possibility that it may be important to health outcomes. And by shining a light, people will start to think about not only those other barriers and those other reasons for inequity, and add this to the conversation when we're looking at outcome data. That would be my take.
I love that idea, Anne, but do you think we can is it going to be part of accreditation? Like, how's that going to, are we going to get the hospitals to start? Is it going to be a part? Like, that's what someone's asked in the chat.
Well, I think if we think about accreditation, we just don't see, accreditation is not some surveyor coming around going, tick, yes, you've got this in place, tick, you've got, accreditation is all about guiding health services as to what is safety and quality care. So it's what happens every day. So I think responsible health service organisations, and I'll leave it to Erwin to comment, will say, well, gosh, we thought we were good. We were trying to be good because everyone comes to work to try to be good. We had a real blind spot. Oh, my goodness, we need to take this on board and do this as well. And so I can't imagine anybody standing at a meeting saying we are interested in safety and quality, but we're just going to ignore this component. I mean, it just doesn't make sense. It's cognitive dissonance now that we know about, you know, the issue. Now that we've got the tools, and whether a surveyor asks you about it is another matter. True quality and safety doesn't come from whether you pass your survey or not. True quality and quality comes from what happens every day of the week in your organisation. And that's why we're moving to short notice surveys, because we don't want to see what you can whip up the week before or the fortnight before. We want to know, everybody wants to know, is my healthcare organisation every day thinking about my safety and quality and that of my fellow citizens in my community? I hope that answers your question.
It absolutely does. And I think it does take that leadership. I should say, Kim, you're smiling. If you want to pop up and talk as well, please do, because I think, everyone's, I think I can see everyone's very excited about this. But
I'm just agreeing wholeheartedly.
Yeah. Go, Margaret.
Thanks, Nadia. I just wanted to say that I think that as far as trying to address the barriers, just going back to the original question that you had, I noticed in the chat they're talking about ensuring that we have a diverse workforce, and I can't overstate that. So that's really, really important. And equally in the boards of the various organisations, really important to ensure that we have diversity there, and that includes cultural diversity and enabling and understanding at the highest level. But when we actually come to practical ways of addressing this, from my perspective in primary healthcare, we have primary healthcare networks, and not all primary healthcare networks actually have multicultural health sections of their primary healthcare network. And I think it would be pretty unusual that a primary healthcare network would actually be caring for a community that doesn't have cultural diversity that they have to address, with multicultural health issues. So wouldn't it be great if every single primary health network actually had a multicultural health section? And wouldn't it be great if they could all connect and actually discuss how they're addressing their particular issues? Because then, and building on what the Refugee Health Network of Australia and various other organisations, when people connect and discuss the issues that they're facing, they find innovative solutions that they then morph to their own regional needs. And I think there is so much that can be done in that sort of situation. And the other thing that happens in those situations is you then get more distilled local engagement. And I know from our experience in our particular area, what we've been able to do is get some amazing people from different cultural backgrounds working together to actually learn through health literacy, building on their own health literacy, and giving them research skills, true research skills, where they can go into their own communities and do qualitative research, gathering data that we couldn't gather, because they understand the way to ask the questions and the way to get the answers, and then bring that from multiple communities together so that we actually have data that enables our health system to be responsive to their needs. And I think that is something that is just essential, where you have the input from communities that may not be able to be English literate. They may have limited health literacy, but they certainly have health needs. And this is a way of enabling their health needs to be heard and ultimately to develop a response to those health needs.
Absolutely. And I think what you're talking about is having a true bicultural co-design approach to, or multicultural co-design approach to healthcare, where representation of the people that we're looking after is seen in the health professionals and the staff and the organisation. One of the organisations I work for, CoHealth, a few years ago did a complete review of their staffing and the cultural diversity in their staffing, and recognised, management is all white and staff further down are not. And how can we change this? How do we turn it on its head? So I'm going to share another story. Conversely, another organisation I've worked with as well had JEDI networks, gender equity, diversity, inclusion networks, which were kind of like peer support networks for people who wanted to address these issues. But there was an institution-wide gender survey, and the results were so bad that in one of these meetings I was told, well, we can't tackle cultural diversity just yet, we've got to do gender. And I was just like, oh, okay. So, to recognise that these things all interact, and I loved the boards thing as well. Because often junior doctors and medical students will all care about these issues. So what can we do? And I haven't actually told them to go join a board, but I'm telling people now from diverse backgrounds, not just junior doctors, but community members that I know through my work, go join a board, get skilled up and be a part of the people that make a difference in the organisation top down. It's a really good advice. There's lots of really good comments in the chat. Did anyone else want to talk about barriers or what they've done?
Just to your point around, your point about, we have to tackle Genderfest, and so we can't focus on ethnicity and race. I think just to make the point that all of these minority group issues, they are not mutually exclusive, and they are not competitive. Because I've experienced that. I mean, I'm involved in a Women in Healthcare Leadership project, and because it was about women in leadership, right? The gender issue, the whole issue of gender identity came up, and what about this and what about that, and so it started to be attacked just based on that, and they're not mutually exclusive issues. We can all work together, because the ultimate thing is to ensure that people who do not have power and influence get equitable treatment and justice. I mean, ultimately it's about justice. It's about, it's the society that we have is not just. And so how do we make it more just? How do we actually work together? And it's not at the expense of anyone else, and that's the key here. So I just wanted to make the point that, we're not fighting for finite resources. We are working together.
Absolutely. And actually, what I love about the standards is it's not very resource heavy in terms of what we need to do. I think there are a lot of things in there that it's there, you've just got to do it. And I just wanted to make a note of a few things people have said in the chat. There are people who have, where is it gone? Who have already done some, I've lost it already. Oh dear, someone's remembered me from 20 years ago in Darwin. I'm all distracted now. They've undertaken a review to see if there were greater rates of, what's HAC, hospital-associated complications? Jackie Stevenson. Yeah, so, to see if there were greater rates for those who do not speak English or born in mainly non-English speaking country. Jackie, what's the answer to your survey? Have you noticed worse outcomes? Can you put it in the chat? I'm curious because I tried looking at that as well. And has anyone else done it for their health organisation? No. Increased length of stay, longer length of stay, increased readmission rate.
So one of the things that Australia, I mean, sorry to speak again, but one of the things that in Australia that we don't do, and someone mentioned this in the Q&A, is that unlike a lot of other countries where they collect racial data, we don't do that. And they do that during a census, but not in a hospital demographic data. When you get admitted, they don't say, what's your ethnicity? They don't actually ask that. They ask you maybe where you were born. And that could be a kind of a de facto kind of way of trying to figure it out. But, and so you might not be able to query that easily, to be honest. And that's, unless you work off the last name of people, you don't actually know their ethnicity in Australia at the moment. And I get the sense that's because it goes back to Australia not wanting to make race an issue, because we want to be equal. Race shouldn't be an issue, but then I'm not sure whether that's right, because clearly race is an issue in our society, so you can't be blind to it. So yeah, anyway, I just thought I'll raise that. It is hard because it's something that all hospitals are kind of thinking about, but how do you measure it? How do you capture it?
It is, and I think it's worth a discussion. I love the fact that Margaret was saying we need to have those primary healthcare networks. We almost need our own peer support network in hospitals about these issues. If we're going to have the standards, maybe we need, and I did this recently at another organisation, a team of champions that we just met regularly and went, this is the issue we're facing about this, and chatted with each other. This is the start of a beautiful discussion, and maybe you've already been doing this for ages in the migrant and refugee health women's network, but this does have to happen. Tanya, you've been quiet. I think you could teach us a lot from what happens in Aboriginal health, actually. It's
no, and I've been quiet and listening to the conversation, and particularly, I mean, I think Nadia and Erwin, your points around, we can't just treat minority issues as exclusionary issues. I mean, really, what a ridiculous notion. I think one of the challenges, and I was going to comment on, I think early on there were questions around mandating and accreditation, and how do you mandate and make standards, mandatory and compliance based. In my experience across the health system, but also in other regulatory systems, mandating standards risks getting people to the lowest common denominator rather than lifting up to the best possible standards. And I say that because, and a few people have mentioned, you know, you don't want a tick the box compliance mechanism, and talked about, you know, kind of rapid. And I know that the Commission actually works with hospitals around accreditation to actually delve in and help them meet accreditation. What, you know, and once again, I kind of go back to the great thing about these standards and this user guide is, here are the questions you need to ask yourself. Here is the mirror you need to hold up to your service. Here are tools and hints that can help you. Here are some great case studies. I also love the fact that we have defined terms in the user guide, because too often we talk about things like cultural competence and assume that people know what that means. And so actually defining it and calling it out is really important. The other part for me is where it works well is it has to be embedded across the system and across your workforce. It's not enough for the CEO to talk about it. It's not enough for a champion to talk about it. It's not enough for a network to talk about it. It has to actually permeate across your whole workforce. I think, you know, Margaret talked about, if your practice manager, if your administrative staff in a primary care setting aren't actually aware of what they can do to improve the access and the quality of care of people, even just trying to access your service, they're not even going to get to the GP. So it has to permeate across your workforce to actually be successful. And you know, as I mentioned, the Aboriginal and Torres Strait Islander space is a really interesting lesson for us, because there's clear measurement. People choose to self-identify and they're given that choice, but there is clear measurement, there's clear data, there's clear recognition that community control and a workforce that reflects the community that it's serving is one of the biggest barriers you can overcome to people accessing your services and actually getting quality outcomes. So yeah, really, really great discussion, but there's some great lessons we can learn across the board. And I do need to take up Margaret's point around PHNs, because they do sit within my group, so I can take that one back. And AIHW, I need to go back and have a look at why, you know, some of the collections, and I suspect it is as simple as we just don't collect that data in a systematic way. So, you know, Erwin, if we can actually get it at the hospitals, once again, is a form that patients fill in, you know, systemic racism in and of itself, right? That's actually the questions you ask and the way that you seek that information already presupposes English speaking in a particular information collection bias.
Absolutely. Goodness, there's so many good gold points being made here. I feel like, I'm sure we're recording it, but you know, I'm just absorbing it all on so many different levels. Everything that you said was completely on point. And I know the Victorian Healthcare Experience Survey is a survey that goes out in lots of different languages, but the people who speak a language other than English are underrepresented in that survey. And you can actually look at how a person who spoke a language other than English experienced their healthcare compared to other people. And I did have a brief look at that, and you actually were more likely to feel overlooked by your doctor if you spoke a preferred language other than English. But interestingly, if you spoke a preferred language other than English and I think had a disability, you were even worse, more likely to feel discriminated against because of your disability. So, you know, these intersections, and I think, you know, you talk about race, but race is a social construct. And so how do we actually get in there? Oh, there's so many good suggestions as well in the chat. I think we're up to answering some questions. So I'm going to put some chat questions to you.
Nadia, while you're thinking about that, can I just draw the audience attention to the fact that if you're working in a hospital with the accreditation standards, under the governance standards, 1.28 does require clinicians to look at clinical variation, and particularly unwarranted variation. So warranted variation, when it meets, it reflects the differences in the needs and preferences of consumers, but unwarranted variation is not explained by that. And I think up till now, we haven't actually really thought about looking at variation in relation to what the expected needs of a migrant group should be and what the hospital is providing. So there is a mechanism, and when we talked before about barriers and facilitators, there's a mechanism now very clearly for health services to really be looking at, do our rates of X or Y reflect the needs of our population? That data can be broken down. So it's a great mechanism to broaden the conversation and broaden the thought process about are we meeting all the needs of all consumers, cutting the data in different ways according to what really matters in terms of getting the right outcomes for people. So I'll just give you that thought.
Absolutely, it's there to be done.
And it is a requirement of accreditation.
Let me see. I'll ask the panel actually, I think, you know, you've all talked to this a little bit. Well, what's something you could do today that would make a difference if you go back to your workplace? I think Tanya said we're going to do the PHN thing, but what's something that you would take home and do today?
Well, I think the user guide for looking at clinical variation, we need a case example that highlights. We've asked people to look at what they've done in the different specialties, but I think we need a new case example that addresses, we'll go out and pursue a group that have done some work around looking at their data, looking at their outcomes, and seeing whether they're meeting the needs of all members of the community. So we'll work on a case example that complements the user guide here and helps people look at their data in that way.
I think we've looked at it for certain conditions. Have you guys looked at particular conditions? So perinatal mortality and morbidity come to mind.
Yeah, I think you're right. Yeah.
Yeah. So there's a particular line in the perinatal and mortality and morbidity Victorian report, at least, I think it was from 2016, 2017. It actually said the rate of stillbirth, the reason I remember this is because, I don't know, I just do, but the rate of stillbirth continues to increase for women born in, and it was like South America, Africa, Sub-Saharan Africa, Middle East, Eastern Europe, compared to women born in Australia. Has anyone seen that?
Yeah, I've seen something like similar. Yeah. I supervised a PhD student that did his PhD on looking at liability and birth outcomes and mothers who sue. It was a medical legal one, and it was very similar. People from migrant backgrounds, and there were some countries that were highlighted had a higher incidence of suing and having bad outcomes. So
at a higher incidence of suing.
Yeah.
Oh, that's interesting.
Having more legal proceedings and interesting.
Were cowed consumers involved in the development of this user guide? Vivian's asking. Who can help us?
I can help there.
Yeah.
We had the most amazing meeting with some very articulate and actually quite young people from cultural and linguistically diverse background who were used to actually engaging with their communities around their health needs and also communicating with healthcare professionals. So they had amazing skills at being basically boundary spanners. And they came down from Queensland to Melbourne and were involved in a whole day workshop and provided enormous insights and clarity of vision that helped, at least that's just part of, there were other people involved as well, enormous number of people involved as well, but they helped set this journey in a really positive direction. And then after that, there was an enormous amount of consultation, obviously with the Migration Council of Australia as well, the Migrant and Refugee Health Partnership. So there is enormous amount of consultation with people from innumerable cultural and linguistically diverse backgrounds. So I have to say, I think that we did fairly well, but I'm sure others could speak to that as well. But it would not have happened without those amazing insights, frankly.
Oh, yeah, absolutely. And I think you can tell that from reading it, actually, I feel. And thanks to Gulnara and everyone who's put it together, there's some really important points in there. And I'm all distracted. Sorry, because Erwin's just told me there's a Q&A panel, Q&A thing in the chat. So, okay. I need a question to answer. Can anyone else see the Q&A? Does anyone just have a look and answer a question for me? You know what's not good is the Q&As are not questions, they're comments. So
no, yeah, I said that to you actually.
Yeah, audience, you're not being very helpful here.
Yep, I think people are meant to write questions in the Q&A.
You're supposed to write questions to make it easier for me.
When we answer them, yeah. I mean, the first one from VJ, should we change from does the patient need an interpreter to does the healthcare worker need an interpreter? I mean, that's changing the locus of focus and control, I suppose. I think that's interesting. But
it's a really good one. So I ran a Zoom yesterday. I was asked to be in a Zoom talking about COVID vaccines and information for the Harari community in Melbourne. And I engaged a Harari interpreter and I said, I need you. I need you to help me. And she said, it's a really good way of putting it, but it is. We're the ones that need the interpreters, not the people that speak the language that they speak. You know, it's a beautiful way of, and I think these sort of frame shifting things really are part of changing culture, aren't they? Having that expectation that we're here to serve and look after our communities. Anyone else? Quiet racism. Why is the government so reluctant to mandate effective data collection on COWD?
I suspect that one's probably for me, Nadia. Although I probably can't speak on behalf of government holistically. And, you know, as I said earlier, I'll have to go back and check with AIHW, but some of the challenges more broadly around data collection, and the government is always thinking about privacy and how is that data used and collected and for what purpose. And quite often the government is restricted in terms of legislation that actually only allows you to collect information for a particular purpose. Anyone who was associated with something as simple as a digital health record for the country will remember the huge privacy debates around the use of patient data. Secondly, one of the things that we are conscious of is, and once again, it goes to safety. People are often very cautious and very skeptical about why governments are collecting information. And if you think about refugee communities in particular, that may have a different relationship with governments and power structures, they may be reluctant to provide that information. So we're conscious about those things as well. And quite often we are also bound by things like the cost and time of collecting information as opposed to, you know, treatment. So there's always those trade-offs. So I know that's not a very satisfactory question to the specific issues of CALD communities, but I'm trying to highlight some of the issues that come up with data collection and with asking people to identify as a particular cultural group or as a member of a particular minority, particularly if it's a minority that has been persecuted in other contexts. So there's some of the reasons.
Yeah, they're good reasons. They almost need training though to ask the question, just like the Aboriginal and Torres Strait Islander question. But Margaret, you're going to tell me.
Well, no, maybe not quite tell you, but can I suggest that a lot of this data collection can happen in the primary healthcare sector? Yep. If we had the 5 fields that I mentioned before, if we actually had them so that they were consistently across all the software that GPs have, just like most of our other data collection things are, then we could actually have, and we would make it voluntary, like it is voluntary to declare whether you're of Aboriginal or Torres Strait Islander background. We would have it so that it's voluntary. mandatory and people could actually, be told. And our RACGP has actually provided guidance around how we can even ask the question. And so their guidance is knowing your cultural background can help us provide healthcare that meets your individual personal needs so that we can help you. Would you like to tell us your cultural background? And then they can determine how they would like to frame that cultural background. And they're also their country of birth. So it's separate. And then, of course, as I said, whether or not they speak a language other than English at home and whether or not they would prefer to have an interpreter in the consultation. And all that sort of stuff can be collected with the person understanding that there's a purpose to this for the delivery of their personal, culturally responsive, person-centered healthcare that's being delivered. Now, once it's in the data fields, it can easily be uploaded into the My Health record, which has already been privacy sorted and everything like that. And it's then available to others to use so that if that person arrives in an emergency care situation, people know as they're trying to wake that patient up or whatever they're trying to do, what language that person needs. That is so hard to ask when a person is, maybe delirious. So understanding that person's cultural and language needs at that moment of emergency care is really vital, and it could be available. Now, it's not going to arrive for everyone in the healthcare record in 5 seconds, but over a period of 5 years, we could have an enormous volume of care. But while we're waiting for that to happen with the enormous volume out there for the Australian data, and which can then be linked appropriately with appropriate ethics, et cetera, if that's necessary. However, what we can do in the short term is because I, in my general practice, are really keen to have that data and my patients are happy to give me that data, making that assumption, I can do my own quality improvement in my practice, and that will still make a difference to people. And in our primary health network, we actually have a tool to enable me to do that. But I don't have the demographic data at the moment to be able to download easily into that tool. So it's going to take me hours to do it, or I could press a button if someone just lets me have the data fields. And I am sure I am not the only person who's really keen to just make a difference to my patients.
Oh, I love you, Margaret. It is true. It is, we need to just, we are doing this on our own. Don't just keep up the good fight. That's what I'm telling, you're not alone, and you're inspiring because we know that you're struggling doing that. And I think a lot of people on the chat are probably doing that too. But if we know that each other are doing it, I think it's a huge, and now we've got the standards to say, we absolutely need this. I'm going to shift sideways a little bit and ask, what, sorry,
come back quickly on the data. And
yeah.
Mark, a really good point. Patients sharing their data with their GP for care and putting it on their My Health record, absolutely, and there's a really important part of that goes to the quality of care that they receive and better outcomes. That's a very different thing to the government collecting that data. And you need to start with that relationship of trust for the benefit and outcome. That data is not necessarily then passed on for research purposes and things like that. But you start there, and you start with that relationship of trust and actually an understanding of why that patient is giving you that data, because actually it improves their outcomes and it makes their story easier to tell every time they intersect with the health system.
Absolutely. Very, very true. So I'm going to shift sideways a little bit, because I think what we'd like to know is, we're talking about practical things, we're talking about data. What can we do to actually address the, I've just lost the question. Oh, yeah, we go. To prevent or guard against tokenism, checkboxing, and that kind of corporate spin on cultural diversity training and all that, it's like, how do we actually, is there any good cultural diversity training out there, or anti-racism training? And how do we actually get it happening? Has anyone had it in their health services and said, oh, wow, that was a great module I did?
Silence, Nadia. I'll jump in. I think the only real way really to guard against tokenism is to have, at the highest level of an organization, the leadership really truly believe that this is an important issue and approach it not from the point of view of, oh no, another thing to have to comply with, but approach it from the point of view of empathy and kindness, and that we're here to look after people. And these are people that are particularly disadvantaged that we need to look after as well. And when you start from that basis, then you create, hopefully through leadership, a culture that wants to express kindness and to serve everyone, including those who might be potentially disadvantaged. So I think that's key. Now, in terms of training, I have to admit, it's all of us have had to do cultural competency training. A lot of places it's mandatory training, and you got to do, you got to attend a presentation, you got to answer some questions, but it's not. I've found it really hard to. I haven't come across one that's really engaging and that's really good. The engaging training I've done is actually more from the point of view of kindness training, just for everybody. How do you tap into why you're working in health in the first place? What your purpose is in life, and how you actually serve other people. That to me speaks more to then help me to then be a better, not just a clinician, but a better person in my work towards everybody, including those from migrant and refugee background. Does that make sense? I don't know if that makes sense, but
I love that. Is this the ethos one at St. Vincent? It's
ethos. We also have what we call formation training, which
everyone needs that at their organization.
It's about, in fact, formation training is about how St. Vincent's started 150 years ago by the nuns from Ireland who came, 5 of them, 9 months on the ship to serve the poor and vulnerable, and how we are doing their work now today. And so to me, that's more meaningful. I don't know. So, but I will be very interested to see if anyone does have a good cultural competency module that can engage people.
Yeah, look, I was being a little bit, look, I love the work of Centre for Ethnicity and Health. And I've also done some amazing work with, there've been some really good Aboriginal and Torres Strait Islander interactive, I actually don't know the name of the one I did last year when I did a little bit of work with the Department of Health and had to do it. And it was quite good. But I think we've got to try and work it out, because I think we've all done ones that aren't that good.
Yeah. There's some examples in the chat that people are sharing.
Yeah, I'm hoping that you collect that
great.
information so we can have it. Now, this is the last kind of question, because I think we're going to have to wrap it up soon. We could talk about this. I feel like I'm in a room of friends and everyone's got the same idea, which is really, I think this is what a launch is about, kind of going, okay, we've got this, we all want to do it. And now just having that conversation, I think, gives us a little bit of energy to get going and keep going and feel that you're not alone in it. So what's the next step after the publication of this standard? Is there a timeline on monitoring and reporting on its implementation?
I suppose the question is from whose perspective. I think the most important thing at this stage is to get it out there, to talk about it, to give people an aha moment that they haven't been thinking about it, they haven't been doing it, and really getting it out as far and as wide as possible, both in the private sector and the secondary healthcare, and getting it as getting it integrated, like we measure and talk about all other sorts of things. We've talked about the differences between males and females in cardiac care. We've talked, and that becomes mainstream. I think the next thing is to make this mainstream as a conversation. But I think going back to Erwin's very important point, we've got to actually talk about it in the context of health outcomes, because that's what keeps it honest. You can talk about it, you can have a concept that you believe in it, but if the health care outcomes don't reflect outcomes that demonstrate you've got equity for people no matter what their cultural background, then you're having a bit of a talk fest. You're not actually doing it. So I suspect the next thing to do is for everybody to be putting it into their way of doing business, and it's as important as it are the other things that you measure, because it is true equity.
Yeah, absolutely. And I think that's what Vijay Roach was trying to say. Are we all in our own echo chamber amongst friends and not actually getting anything done? And actually what we need to do is get these outcomes. And I should say, I think it's Nadine who said, you know, I agree, we cannot be culturally competent in anyone else's culture but our own, but what we can be is responsive. Did anyone else want to add?
The accreditation will drive it, because people will be thinking, I'm about to be accredited, how are we doing? But I think that's a secondary tool to the action, but it helps people getting it into the conversation.
Margaret?
Yes, Nadia, it's just building on what I said before, that I think the primary health networks have a really important key role here. I think if all the primary healthcare networks are actually primary health networks are actually aware of this particular resource, I think it should be promoted actively. And I think there is a role for the primary health networks to discuss with their local hospital and health services that they engage with all the time, to actually be asking from the community, which they're connected with, to the hospitals, what are you doing in your hospital sector to address these issues? And then reflecting back, how can we support you in doing that? So it's a two-way street again, but they're with the hospital service and the primary health network services working together to actually make a real difference in the local community. I think that's where we'll see a capacity to respond and to actually enable action that's relevant to the local communities who need the support, as particularly the vulnerable communities.
And someone in the chat was asking whether it's appropriate to send the guide out, to their particular networks. I'd be encouraging the people online today to be sending it far and wide. The more that it's disseminated, the more people know about it, the more people understand the tools and how to use it, the better it will be.
Absolutely.
Absolutely.
I'm going to end with something a little bit controversial, because that's, me. I really don't like the term vulnerable. And I know we use it a lot, and it's kind of put in many of the people I work with from many diverse backgrounds and intersections of less advantage or underserved by our health system are that they're underserved. They're not necessarily vulnerable, but it's the policies, the practices, and the people that make them vulnerable. And it would be, I think it's worth kind of then, thinking about that word and whether we should be using it, because the people that I work with from many different backgrounds who have that migrant story, who've gone through a lot of challenges that I couldn't even imagine, are anything but vulnerable. And then we kind of put them in a health system that gives them worse outcomes. So we've got to work out how to change that.
Nadia, that is an amazing point to end on and give everybody some food for thought there. We are sort of coming towards the end of our time anyway, and I would really like to thank you so much for the way you've chaired the panel today and all the work that you're doing. And I'd really like to thank all the people on our outstanding panel. There's just so much passion and so much commitment that we've just witnessed. And thank our audience as well for the comments in the chat and the questions to make the discussion so fascinating. There's so much more we could say, and there's many more questions than we've got time to answer at the moment. And as we've highlighted, this is such a complex and multifaceted topic of discussion. And our discussions, included the need for empathy and kindness and the importance of quality measurements. Some challenges have been thrown out to people in various directions, not to mention the use of the word vulnerability and vulnerable individuals. Clearly so much more to say, on this. So I want to sort of bring the launch to a close by saying yet another thank you to everyone who's contributed to this significant resource. And I'm just going to make a couple of comments about the format of the resource, because the wonderful panel have done the right thing talking about the content and everything. And a couple of little comments have come up about the format of the resource. And please don't think me trite when I'm saying this. It's really user-friendly as far as user guides go. And when I looked at it, I really love the reflection that you're asked to do and the points that you're asked to consider as a user of this guide, the tips and the suggestions for other strategies and things, and the links on to other resources. So it's a particularly useful user guide. And as has just been stated, let's just get this out there far and wide in whatever networks, contacts we've got. And we do need to monitor its rollout and monitor outcomes from this guide. And I think we all need to have a look at ways of how we can be involved in that, because how we monitor it will depend very much on the organisations and the institutions that we're working with. But we probably need some overall data as well. So once again, thank you to everybody who's been part of this. Thank you to the wonderful panel. Thank you to the Migrant and Refugee Health Partnership. And I feel a bit like I'm doing an Oscars speech now. And thank you to the department, and thank you to the Commission, and thank you to the Migration Council of Australia. I would just like to declare this user guide well and truly launched at the moment, and thank everybody for their participation and attendance today. And I wish everybody well. Please stay safe.
Thanks.
Thanks, Kim.
Thanks, Kim.